Good morning, good evening, and good night, as applicable. My name is David Banks, and on behalf of the entire Theorizing the Web organizing committee, I'd like to welcome you to today's episode of Theorizing the Web Presents No Body. Theorizing the Web is our series of talks about technology and society. New episodes will stream live on selected Wednesdays at 2 p.m. Eastern Time, and we'll also announce some special events later this fall. If you'd like to discuss today's episode in real time or submit questions for Q&A, please join us in the TTW Discord. You can find the Discord back channel by following the link in the description of this YouTube video and on our website, theorizingtheweb.org. Before we get started, I'd like to thank the production team at the Museum of the Moving Image, without whom Theorizing the Web Presents truly would not be possible. I'd also like to thank my fellow organizing committee members, as well as all three of today's panelists. And on behalf of all of us, we'd like to thank you for watching and participating. If you like today's talk and want to see more, please consider making a donation to both Theorizing the Web and the Museum of the Moving Image. Every donation lets us produce more content like this, and we're grateful that we can do that with you. And with that, I'll turn it over to today's moderator, Whitney Aaron Basel. Whitney Aaron Basel is an independent researcher and freelance editor whose work focuses primarily on the sociology of health, medicine, and technology. Her writing has appeared in Time, The New Inquiry, Cybergology, and Huffington Post. She is also the producer for Theorizing the Web Presents. Take it away, Whitney.
Thank you so much, David. And thank you to everyone who's watching live today. Today's episode of TTW Presents puts medical and non-medical ways of knowing in conversation with each other to discuss two very different somatic phenomena, endometriosis and ASMR, or autonomous sensory meridian response. Endometriosis is a medical diagnosis, but it is also understudied and poorly understood as a condition. Conversely, current medical research can neither diagnose nor explain the phenomenon of ASMR. Today, we will hear from two speakers who consider the intersections and interrelationships between institutional medical knowledges and some of the patient-centered knowledges that circulate on the present-day internet. Our first speaker, Eileen Mary Holoka, is a writer, game developer, and PhD student who is currently studying feminist social media practices around chronic pain and invisible illnesses. In 2018, she created a digital narrative circuits about the difficult act of narrating sexual trauma within institutional spaces, which can be played for free online. And with that, I will turn it over to you, Eileen.
Thank you so much, Whitney. I'm just going to share my presentation here. All right, so today's presentation, Hysterics on the Web, is a short look into my in-progress dissertation research in communication studies. This project focuses on a specific but quite large group of people who live with a condition called endometriosis. And I consider how they use social media, specifically Facebook and Instagram, to navigate, manage, represent, and live with their illness. So to start off, what is endometriosis? Endometriosis is a devastating and painful condition that is overwhelmingly mistreated, underrepresented, and misdiagnosed, despite the fact that it affects 1 in 10 individuals assigned female at birth, and sometimes very rarely appears in individuals assigned male at birth. Endometriosis is a condition where tissue similar to the lining of the uterus grows outside the uterus. This tissue can cause debilitating pain, infertility, organ dysfunction due to inflammation, invasion into structures in the body, and scar tissue. Unfortunately, it is regular practice for individuals living with endometriosis to experience dismissal and mistreatment of their symptoms, making the average time from the onset of symptoms to diagnosis 10 years. At the heart of a lot of this dismissal is the idea that painful cramps, which is already a very limited description of what the condition of endometriosis actually is, that these painful cramps are normal and that patients complaining about these symptoms are either overreacting or just untreatable. These responses are untrue on a number of fronts. Endometriosis is treatable with the proper kind of surgery and other tools, and the pain caused by endometriosis is very real and often considered equivalent to or worse than childbirth. Further, the symptoms range far beyond just painful cramps, including but not limited to severe, sometimes debilitating pain with or without menstruation, nerve pain, pain with sex, stomach digestive problems, extreme fatigue, infertility, and even, in the case of thoracic endometriosis, lung collapses and or coughing up blood. Despite these symptoms, and despite the fact that this condition affects millions of people worldwide, most of whom don't have access to proper care, endometriosis is a word most people don't know, doctors included. If someone has heard of this disease, it's often because they or someone they know has it. So why is this the case? Most people theorize that this is due to the gendered aspect of endometriosis. That is, how it's presumed to be a woman's illness because of its connection to the uterus, as well as the more general cultural stigma around menstruation. And I can say that this has been pretty much unanimously confirmed by the interviews and surveys I've conducted so far. Most of my participants identified some kind of unspoken idea that neither pain nor menstruation should be discussed. And this was particularly true for the people of color and genderqueer participants I interviewed, where cultural differences and gender stereotypes enforced particular kinds of taboos. This discriminatory treatment of endometriosis is an extension of a long history of sexism and medical and cultural dismissal of what's sort of referred to as female pain. And this is why I playfully use the term hysterics in my title. As endometriosis specialist Dr. David Redwine explores in his book, Googling Endometriosis, many of the early diagnoses of hysteria were likely endometriosis. He illustrates how the basis of endometriosis treatment today is built on a series of myths dating back to as early as 1825 BCE. Those with endometriosis today are, as he writes, trapped by errant words from the past. As early as 400 BC, doctors were already blaming women for these symptoms, citing such things as that she must have had too much sexual intercourse or poor morals, in lieu of their lack of knowledge around treatment. Although the knowledge around women's pain has progressed over time, what is most astounding is the lack of progression in treatment. Today, we have the research and knowledge to properly treat people with endometriosis, but in many ways, the transvaginal leachings and other horrifying treatments of the past have just been replaced by other provisional and sometimes very risky treatments, including at times, sometimes potentially very dangerous medications, such as Lupron, which induces artificial menstruation. While these treatments work for some individuals, they can also cause irreparable damage, including bone density loss or permanent lasting pain, and they don't address the root of the condition, which is that tissue growing and sticking to organs. And this can open up a whole other topic, a whole other can of worms when it comes to pharmaceutical companies funding endometriosis organizations or certain doctors to push these medications onto patients, which I don't really get into today, but these companies also have social media pages and their content does get absorbed into the body of work that I'm considering in my research. So I've included a post here by one of my lovely research participants who uses the handle The Endo Monologues based on the play The Vagina Monologues. And she writes here, female hysteria? Why yes, being misdiagnosed time after time does make me hysterical. And I think this is a great example to get a quick glimpse into some of the creative and critical work that takes place in these endo social media spaces. I love the tongue-in-cheek way in which she repurposes hysteria, flipping that term on its head to show how the source of hysteria is not from the patient or her condition, but rather from the medical system that is supposed to be helping her. And this is where the theorizing the web aspect of this research comes in. As of right now, there has not been much of an exploration into the use of social media by people with illnesses or chronic conditions that is also in conversation with feminist social media studies or disability studies. There is a wonderful book by Stephen Rains called Coping with Illness Digitally, which considers how people with chronic illnesses use social media as a coping mechanism. He identifies some of the reasons why people turn to social media, including making and reinforcing connections, soliciting and providing social support, sharing illness experiences, seeking health information, and so on. I would say that my survey results do largely reflect this data. However, these needs do vary between different conditions, and certain conditions also have a much larger online presence than others. I argue that endometriosis has a very particular history of sexism and mistreatment that pushes patients into these digital spaces out of necessity and a lack of other options. For endometriosis, the primary reasons that were identified in my survey, not my surgery, in my survey as to why people turn to social media were for support and to combat isolation, followed closely by the sharing and receiving of medical information, and then the ability to describe or vent about one's experiences. 90.8% of the almost 300 people I surveyed had learned something new about endometriosis from social media that they were not exposed to elsewhere. Many of the entries on what they had learned were about treatment options for their condition. And this is one of the things that makes online endometriosis spaces so interesting. Self-education about endometriosis becomes necessary for these patients in order to receive adequate care. And although some of the Facebook pages or social media groups focus solely on support, many of them focus entirely or at least somewhat on self-education. The best example of this and kind of the go-to space for endometriosis education online is the Facebook group Nancy's Nook Endometriosis Education. At the time of the screenshot, Nancy's Nook had approximately 113.9 thousand members, and it's growing constantly. In my interview with the owner, Nancy Peterson, she says they get approximately 40,000 posts a month, and she donates 60 to 70 hours a week into the page, despite also having 13 to 14 assistants and moderators. Nancy's Nook is highly moderated and doesn't allow support posts, but rather focuses on self-education and research. The Facebook page hosts extensive files and research on endometriosis, what it is, proper ways of treating it, lists of doctors that have been recommended by the community, protocols on how to prepare and recover from surgery, and so on. There are actually doctors within this Facebook group who will sometimes participate to answer questions that patients might have. And users are told to wait a week after joining to read the resources before they ask a question. One of my interview participants says that she reckons endometriosis patients are some of the most well-informed patients out there. Despite that, Nancy Peterson has identified that 75% of patients get dismissed as being neurotic. This emphasis on self-education has also fed back into my own research. It's thanks to spaces like this one and the openness that folks with endometriosis have around bringing awareness and gathering research that I was able to get so many participants in this study. I surveyed 284 people, and I'm set to have done one-on-one interviews with 25 people by the end of this month. And I'm happy to talk more about my methodologies later if you want. But I think an important aspect of this research was that it's also autoethnographic. I came into these spaces as someone with endometriosis myself, and often was welcomed by participants because they felt I knew what they had been through. And I did, often. I was diagnosed with endometriosis 2 weeks into starting my PhD during an exploratory surgery. When I posted to Instagram with my post-surgery news, I had already self-diagnosed my symptoms about 2 years prior, entirely through my own research, much of which was guided by social media. And I have included an image here of me with my little surgery scars. This was probably my most popular Instagram post because I'm not as good at social media as my participants are. But what's interesting is that just by using the hashtag endometriosis, I got all kinds of people I'd never met who had endometriosis commenting to offer support and advice and to commiserate, which I find really interesting. And I want to specify here that I'm not trying to advocate for social media as some sort of ideal platform for these conversations or even for support. And I can talk a lot about how that's also not the case, but rather that these platforms, specifically Facebook and Instagram, do have certain affordances that people use in incredibly inventive ways to advocate for what they need. One example of that is how individuals on Instagram will find ways of making visible an illness that is otherwise rendered invisible, sometimes even to doctors in a surgery. Sometimes this is done by showing scarring from overuse of heating pads or by painting one's stomach in ways that evoke the kinds of pain happening inside. But in this post I've included here, you can see one of my participants, Maddie Morneau, bent over in pain on a stool in the shower. In the side text, she describes not only the physical sensations of endometriosis pain, but also all of the other feelings that come from living with this disease, such as feeling like your goals are only getting pushed back instead of inching closer to them, feeling like you're on a time crunch to have a baby you know you want before the insides get damaged to the point of no return. And this is where my research brings together feminist media studies, disability studies, and endometriosis through the use of affect theory, particularly the approaches of scholars such as Sarah Ahmed, who considers how feelings circulate and stick, and through that stickiness create meaning. Where endometriosis tissue can literally stick organs together, the ways it is negotiated, represented, and researched online also creates and recreates what endometriosis comes to mean to people, and even how it can come to be treated. As Ahmed writes in her book, The Cultural Politics of Emotion, the very words we use to tell the story of our pain also works to reshape our bodies, creating new impressions. So to finish off for today, although endometriosis gives us one specific glimpse into this world of media creation, we see it happening again now with long haul COVID-19 support groups. As Professor Felicity Callard and Dr. Elisa Perigo recently wrote for the journal Social Science and Medicine, patients themselves are actually responsible for coming up with the term COVID long haulers, as well as for establishing that condition's symptom list and advocating for their own medical treatment. So you can see the comparison there. And that's where I'll have to stop for today, but I'm happy to talk about any other parts of this later if anyone's interested.
Thank you so much, Eileen. With that, I would like to introduce our second speaker, Dr. Nitin K. Ahuja. He is an assistant professor of clinical medicine in the Division of Gastroenterology and Hepatology at the University of Pennsylvania. His primary clinical interest is in motility and functional disorders of the gastrointestinal tract. His secondary research interests are in the history, literature, and culture of medicine. All you, Nitin.
Thanks so much, Whitney, and thanks to everyone listening. I'm going to share some slides as well. So I'll be talking about ASMR in the clinic. Over the decade or so since autonomous sensory meridian response, or ASMR, was codified by name as a shared psychosomatic experience, familiarity with its associated media content has filtered steadily into the cultural mainstream. I've noticed that my invoking the phenomenon with friends and colleagues has required less and less background explanation. Through viral parodies, as well as straight-faced branding campaigns, the trappings of ASMR-oriented media, for example, whispered monologues, binaural microphones, and prolonged close-ups, now constitute a recognizable audiovisual shorthand. At the same time, efforts to construct an explanatory biological model for ASMR seem to have stalled. Potent clinical tools like functional brain imaging and validated questionnaires have yielded little insight to date into the mechanisms behind the prototypical tingles of ASMR, the pursuit of which continues to energize this online community. Halting efforts have been made to study the phenomenon in the context of placebo-controlled trials, but the limits of this methodology seem to follow directly from the challenge of simulating an intervention that is itself a simulation. These clinical modes of inquiry have faltered despite the ASMR community's persistent engagement with conventional clinical tropes. The routines of conventional healthcare, from structured medical histories to focused physical examinations, remain a popular template for ASMR roleplay online. Adjacent media forms characterized by more explicit strains of medical exhibitionism, for instance, the work of the self-styled Dr. Pimple Popper, suggest the existence of a larger family of clinically rooted sensory phenomena and triggers. The clinical relevance of ASMR extends to its reported outcomes as well as self-guided treatment for migraines, insomnia, depression, and anxiety, diagnoses that are formulated within but often failed by orthodox biomedical paradigms. Relative to conventional clinical research methods, I want to suggest here that an evolving understanding of the notion of placebo might offer a clearer view of the mechanisms behind ASMR-oriented media. In basic ways, clinical role-play videos can be viewed as analogous to sugar pills, medicinal in appearance but inert in composition. While a few ASM artists have a real-life medical background, the majority of them don't. Some stumble charmingly over clinical jargon, while others lean obviously into the absurdity of the conceit, substituting children's toys for standard diagnostic equipment or improvising new diagnostic maneuvers with no discernible purpose. In all cases, the asynchronous nature of the therapeutic performance is inescapable. Viewers enter the encounter long after their caregiver has left it. Ted Kapchuk, a medical researcher at Harvard Medical School who directs the program in placebo studies, has defined placebo effects as, quote, improvements in patients' symptoms that are attributable to their participation in the therapeutic encounter, with its rituals, symbols, and interactions, including identifiable healthcare paraphernalia and settings, empathic and intimate witnessing, and the laying on of hands, unquote. It strikes me that many ASMR videos, whether or not they're clinically themed, map functionally to this definition quite well. Above and beyond plastic stethoscopes or virtual backgrounds of examination rooms, therapeutic value is distilled in prolonged acts of personal attention, punctuated by the recognizable tics of kind people with time to spare who are just a little bit worried about you. Their probing expressions, for example, and rambling explanations and soft clucks of the tongue. The word placebo tends to carry stigma. Within medicine, it's viewed as a nuisance that clouds the detection of quote unquote real clinical efficacy. Outside medicine, its use can be similarly dismissive, suggesting that the mind is playing tricks on the body and that any suffering thereby mitigated is also to some extent imaginary. Stakeholders in placebo studies argue that these definitions are reductive, citing both the complex neurobiology that underlies the placebo response, as well as the much simpler idea that at the end of the day, medicine exists to relieve distress, not to delegitimize it. This interesting study by Kapchuk's group in 2010 among patients with irritable bowel syndrome showed that a placebo intervention could yield symptomatic benefit even when the patients were told that the intervention they were receiving was a placebo. These results suggest that the placebo effect need not operate in the dark behind curtains in hushed voices. Rather, we could discuss it frankly and maybe even optimize it for use in practice. The ASMR community would likely regard it as obvious that the theatrical trappings of clinical encounters could prove therapeutic, even when unbundled from real-life medical care. This insight recalls for me the recent history of cognitive behavioral therapy, or CBT, a mental health intervention developed over the course of the 20th century. Initially, extensive professional training was thought to be necessary to effectively deploy CBT, but over decades, as the modality was refined, its success was demonstrated in the hands of a much more diverse range of practitioners. The more recent paradigm of internet-delivered CBT has also demonstrated effectiveness with or without an active human facilitator, useful proof of concept for wellness that can be achieved online through pre-recorded media. The current pandemic has brought with it a massive overhaul to healthcare delivery, my own practice included. Last spring, I got pretty familiar with the telehealth interface, which many of my patients continue to prefer on the grounds of caution, convenience, or both. After a day full of these encounters, I confess to feeling my attention degrade. It takes more energy to engage with the stories that patients put forward and more time for me to remember those stories afterwards. At the same time, I'm struck by the increasing proximity between ASMR videos and my own therapeutic output in the context of telehealth, to the extent that I too am performing empathy deliberately across the obligatory social distance. It's impossible to ignore my own face in the corner of my screen, contorting in ways that I recognize from YouTube, launching into scripts that feel at once intimate and automated. As a genre, ASMR subsumes much more than the theater of compassion that I'm describing here. There are conceits of cruelty, of fantasy, of frank sexuality, and wordless disembodiment. Likewise, it feels important to mention that not all strains of physical suffering are equally susceptible to a placebo response. It's by no means implied, for example, that the 2010 study of open-label sugar pills in IBS would have had the same results in colon cancer. That being said, I think a more granular understanding of the therapeutic potential of ASMR-oriented media could provide opportunities to augment real-world therapeutic practice, particularly in a modern healthcare environment with so much cause for disenchantment. The increasing technological complexity of modern medicine, from the documentation requirements of electronic medical records to the architectural sterility of contemporary mega hospitals, is often reflexively regarded as dehumanizing. So it's refreshing to think about online media as offering potentially humanizing solutions. In my clinical practice, there are more patients than I'd like who never end up feeling better. My list of available prescriptions isn't infinite. So I welcome the opportunity to increase the healing potentials of medicines that are usually taken for granted. The arch of my eyebrows, for example, or the cadence of my voice. In general, I read the ongoing formal innovation within the ASMR community as an excavation of performative tools that are already buried in analog therapeutic encounters. Once dusted off and examined in the light, they could certainly be better centralized and more deliberately deployed.
Thank you, Nitin. At this point, I'd like to invite Eileen to join us for Q&A. Welcome back. And again, if you're watching this live, please do feel free to submit questions for Q&A via the Discord. So to start, among each of your populations, you have people who suffer from endometriosis and people who experience ASMR, what is the predominant attitude within each population kind of toward the medical establishment writ large?
Eileen, should I take it?
Oh, you can start us off, yeah.
Okay. I don't know. I feel like I can't really speak to the ASMR community as a whole, but it doesn't seem hostile. I think to the extent that there's a kind of pantomime happening of clinical encounters, it feels playful and improvisatory and like the sort of body of knowledge that can be borrowed from in sort of an adjunctive way. So this too feels like it dovetails with the sort of positive vibes that I get from ASMR generally as an online phenomenon, to the extent that so often there's like a knee-jerk sort of cynicism towards like what's happening on the internet. In general, it feels like a feel-good kind of community.
Yeah, I'll say it does vary within the multiple communities of folks with endometriosis, but a lot of those people are really burned out from bad experiences in healthcare. And I don't want to say that they're just dismissive of healthcare for that reason, but they know often how to work their way around things. They know how to perform in ways that will get them the care they need. It's like a kind of whole knowledge base that comes out of not being heard in many ways. And that's not the case for everyone, but it's the case for a lot of people. And it differs also between regions. So folks in the States have difficulty raising money for their surgeries, whereas folks up here in Canada have difficulty getting in to see doctors. It'll take like year-long wait times and stuff like that. But the cool thing is when there are practitioners who are really invested in endometriosis, there is a really great patient-provider kind of relationship that happens, especially because so many of these patients are doing the work to try and educate themselves, and they do want to reach out to doctors in that way. So
cool. So in a similar vein, to the extent that you can each comment on it, how important to each group is recognition by institutional medicine? Like on the whole, are your populations seeking acceptance or to be seen as equal authorities in knowing about their bodies or something else?
Well, I can start that one if you want. That's huge for folks with endometriosis. And a lot of the people I talk to are doing advocacy work. A lot of them didn't expect to ever do advocacy work in their life and find themselves doing it because they just need it so badly. And they don't want anyone else who had to go through what they've gone through, basically. But it's just an uphill journey, because as I've mentioned, there's like been so many years of endometriosis existing. It seems like by now there should be more recognition.
Yeah, I think the incentives of the ASMR community, again, heterogeneous, but don't feel as caught up in tension with what's available from orthodox biomedicine. I think it's to the extent that it was formulated initially as a subculture, it doesn't sort of exist in opposition to more dominant culture. I think in sort of available dialogue, at least that I've accessed, there's certainly curiosity about validation from sort of biomedical methods, that there ought to be a way to pin this down through sort of available objective tests, but it doesn't feel existential. I think, to the extent that ASMR, people who experience ASMR are sometimes stigmatized as experience some sort of deviant phenomenon or sort of parasexual phenomenon. I think legitimacy would be helpful in that regard, but to the extent that I don't know that it's as much of a urgent need as it is for Eileen's community of focus, for example.
So one thing that came up a lot in my own research, like 6 to 10 years ago, was physicians who had a really dismissive view toward internet-facilitated patient advocacy. In particular, a number of my informants made cracks about patients who consult Dr. Google. And they really hated that, the people that I was talking to then. Nitin, this is part of why I found your talk so fascinating, is because here you are, you're an actual doctor, and you're making the case that physicians really have something to learn about how to practice medicine from an internet subculture. So to you, I would ask, do you find that other doctors are open to this kind of perspective, or that you're something of an outlier among institutional medicine? And for Eileen, I'm really curious to know if physicians have become more willing to engage with patients who do their own research since I was last talking to a whole bunch of physicians.
Yeah, I can't speak for sort of whole groups of people, but I've certainly encountered people in both camps among my colleagues, like people who are exhausted by the prospect of misinformation online, leading to atypical heterodox health beliefs among patients that can be, at worst, like dangerous, really. So, I respect the reflex to turn away from misinformation in certain circumstances. But I also, encounter people who are very much like me, sensitive to the idea of the fact that the history of medicine is littered with examples of hubris, and that we don't know everything, and often end up with egg on our face for calling like multiple sclerosis hysteria or whatever. So that's sort of my attitude towards crowdsourced knowledge and techniques, thinking always about sort of risks and benefits, that if I can't see any obvious harms to a practice, then it doesn't immediately strike me to foreclose upon it. And things that are outside the bounds of biomedicine. I mean, biomedicine is a bounded practice, so there are limits to our knowledge for sure. And wherever we can reach to gain new sources of knowledge that might be nourishing to the practices as a whole, so much the better.
Yeah, I think I feel similarly to Nitin. I think something that can be a bit frustrating is, and I think it's changing a little bit in scholarship, but often, even within communication studies and such, there's a tendency to, when looking at patient support groups, a tendency to focus on misinformation and harm. And I understand where that comes from, because that is a very real concern. And I've seen it happen within certain groups that I'm looking at as well. But I'd argue that that's not all that's there. And I'd also argue that there's there's something very important in the fact that so many people are turning online for information. And in the case of endometriosis, that's often because all the other options and resources have been exhausted. So I think what we've learned too from chronic pain research and research into patient-provider relationships is that patient-centered care is a really critical thing, and it's a really generative thing as well, where there's a collaboration between patients and their doctors. And in the ideal world, I would love there to be a space where a patient can come in and say they've looked something up online, and that can be a conversation as opposed to an immediate dismissal. Because there's a difference between Googling something and there's a difference between going to a space like Nancy's Nook that's full of research articles. And it would be great to just have that conversation, see where a patient's coming from. Obviously, there's all kinds of constraints that make that more difficult to do in actual practice. But yeah, I think that's everything I had to say about that.
Before we start taking some questions from the Discord, is there anything either of you would like to ask the other?
Ooh.
Or you can think on the first. Oh, do you have a question?
Yeah, well, I mean, I was really struck by affect theory and I don't know anything about it, but the sort of somatic metaphor of like circulating sentiment, if I have that right, and then sort of accretion locally, and obviously that maps quite well to, you know, the physical model of endometriosis that you presented. So I guess what's underneath that in terms of, I mean, is it just sort of a helpful rhetorical model for sort of thinking about it in this context, or is there something to connect the sort of the emotional and the physical in the context of this particular disease?
Right. Yeah, I think so what I find interesting and useful about affect theory, especially Sarah Ahmed's work, is this circulation of ideas and how we can apply that to social media. So the ways that certain ideas and feelings stick, and the ways that affect drives different tendencies online. And there's different affects for different endometriosis Facebook pages as well. If some might be more towards sympathy and support and venting, others are more oriented towards research. And I would say that's affect theory is a great way of getting into those nuances. Then it just has the fun aspect of like stickiness being something that's also embodied within endometriosis. But what's cool about that too is what we know about pain. It is something that is both embodied and also something that comes from outside, from the way that we understand ourselves and understand our lives. And so there is some cool work that sort of jumps between neurological understandings of pain and affect theory as well. That it might be harder to wrap my head around sometimes, but are, I think, like a great place to jump into.
Yeah, that's fascinating.
I don't know if this is a question per se, but I really liked the idea of performing empathy and care. And I think that's an interesting part of being a practitioner that doesn't necessarily always get emphasized or talked about as much as the practical knowledge of like applying medicine. And I know narrative medicine sort of practices have taken that up and applied them into programs, but I'm interested if like a lot of the work in care and empathy has come out of your own personal investment, or if it's come out of classes you took, or how that.
Yeah, it's a, I got interested in ASMR as a trainee, and that's sort of like historical circumstance, I think, but it's always been the clinical role play that has been like the subset of ASMR that's interested me the most, just because it it resonates with sort of my early experiences as a trainee when I knew nothing of practice really, and we learned from the beginning sort of how to go through the motions of a clinical encounter. Leslie Jamison's empathy exams essay like made this kind of famous, this sort of standardized patient encounter, and how the sort of bewildered medical student has to like perform empathy without really knowing. And so it's sort of struck me, I mean, all of medical training to me, medical school felt very performative. Like I didn't really know what I was doing. And you learn how to ice the cake before really having a cake to ice. And so now that I have a cake, it's interesting to attend to how easy it is to forget the icing. But both elements are sort of necessary. And I think I still I'm fortunate enough to work in a practice that allows me time to sort of think about both things. I think a lot of harried physicians just need to get this sort of information out and forget to sort of deploy it deliberately and slowly. I think time is really the sort of key ingredient that allows me to be like a three-dimensional human.
So right now we have 3 questions from the Discord. We'll see if any more pop up while we're talking. But the first one is, the question writer writes, I, for one, would be interested to know if patient-led movements to recognize endometriosis have to keep terrible conspiracy theories like anti-vax people out of their movements and not get painted with a broad brush that kind of connects the two things.
Yeah, it's a good question. And it ties in with what I was saying earlier, where my fear is that these things get painted with a broad brush so often. And that's something that I think frustrates a lot of patients and can frustrate me as well. It's really different depending on the space. In a super moderated space like Nancy's Nook, conspiracy theories are going to be shut down. Like they're not even going to see the light of day. In more open-ended support groups, it's more of a free-for-all. I'd say I'm surprised that not surprised, but I'm glad that I haven't seen more like anti-vax stuff. And what's interesting actually is when there was that panel of doctors supporting anti-mask stuff in the States, one of them had this history of saying that endometriosis was caused by having sex with demons in your sleep. And I mean, it was really great and refreshing to see that go through these spaces and people take that apart and do a lot of critical thinking and venting and getting out their anger at that. And so I want to say that I think there's a smartness and an intelligence to these people that is easy to dismiss. And that's the case for all online activity, that even when people are sharing conspiracy theories, the kind of media spaces that we've created make that a muddy and complicated thing. And so, well, yeah, stuff can circulate. I'm more interested in sort of how people are getting there in the first place and what's bringing them there.
The second question is kind of a follow-up to that.
Oh boy.
It's, it would seem to go hand in hand with the feeling behind both movements, by which they mean kind of endometriosis, self-advocacy, and then fringe conspiracy theories. Pick your fringe conspiracy theory. That both movements, it's the desire by patients to become validated sources of their own concerns and health, instead of surrendering that power to an expert certified by the state. And they are interested in hearing about how the two approaches both utilize social media for community building. If either one of you can speak to that. I don't know if there's a lot of conspiracy theory in the ASMR community, but.
I guess one thing I could say is that I think, well, self-empowerment is important. I think a lot of the people in endometriosis communities would love to hand knowledge over to someone else. and love to hand that power over. But they've just had to become self-empowered out of necessity. So maybe in that way, there's a bit of a distinction between like wanting to push away from authority figures, although that certainly crosses over. I don't know if Nitin has any thoughts.
Yeah, I mean, I've been listening to a podcast called Conspirituality that's been talking about the sort of convergence of like left-leaning, new agey movements and red pill, MAGA, QAnon phenomena, and they draw interesting links between the two. I mean, on the surface, it would seem that these two sort of communities are antipodal, but it has to do in their minds with sort of self-sovereignty, like you mentioned, Whitney, and I think sort of harmonizing scrutiny of systems of power that are sort of opaque and, what aren't they telling you kind of stuff. And so I think, Eileen, it's a useful distinction for you to draw that like this is not an active choice that people in marginalized disease communities are making, that it's a sort of by necessity. But I guess you could, I mean, to make the counter argument, I don't feel that this is true, but like to draw a through line between the two, you could suggest that like one form of chronic marginalization or disinformation or breeds distrust that then might ripple forth into other dimensions of sort of healthcare. I mean, I don't think that's true to the extent that you've mentioned that there's like a great deal of buy-in into sort of peer-reviewed literature and partnership with sensitive clinicians, that it's really just sort of a lack of available partnership rather than sort of turning away from what's available. But well, those are some.
Yeah, I do actually. I think affect theory is a useful way of thinking about this again, because and community as well, because I don't remember who the piece is by, but there's writing about women in the KKK being a part of it because it was their community, and that's the only community they had. And I think we see that in conspiracy theory groups online or offline, and I think that happens the same in any kind of community. And some of these endometriosis spaces are communities, and those communities have different feelings and sentiments and attachments that make them the space they are. So that's a sticky thing as well.
Okay, so our final question from the Discord is, what's better? Health professionals being more open to patient-led research and diagnosis, or more trusting health professionals that would obviate patient-led movements?
Both. I'm not sure.
It seems like one facilitates the other. To the extent that biomedicine is a bounded practice, I don't know that I could imagine biomedicine ever being so porous that everything is fair game in terms of what's formulated on the outside of it. I think there does need to be sort of a process of filtration that's in place. To the extent that we're talking about health beliefs that are completely unfounded or like objectively dangerous. I mean, there ought to be some. I don't know that we need to dismantle the entire enterprise, right? I feel like the sort of like separation between healthcare professionals and patient advocacy groups it entails there's something produced in the tension as opposed to like a complete conflation between the two. Maybe that's the way to say it. but certainly we're not there. We're not close to there.
Any other closing thoughts? Awesome. Well, I want to thank you both for a really great discussion. I was so excited to moderate this panel. To everyone who's watching, please tune into our next episode. It will actually be next week, October 28th, Wednesday, 2 p.m. Eastern, 11 a.m. Pacific. And that episode is titled Street Smarts. After that, we're going to take a 3-week break because we expect that the media landscape in the United States is going to be a little crazy, but with the election. And then we will be back on November 18th for the rest of season 1. So thank you so much for being here today. Thank you to Eileen and to Nitin, and thank you to all of you.
Thank
Bye.
you.
Thank you, Annie.